oncologist, National Cancer Institute, Dr. Nora Azman bin Mohammad Rosli, public health physician and senior principal assistant director, Vector-Borne Disease Unit, JKWP, KL and Putrajaya. Thank you for joining us and for lending your expertise to this session. Before we begin, I would like to give a brief explanation of the competition rules. Presenters, now listen carefully. Each of our presenters will have 10 minutes to present their work. Please stick to the allocated time, as chairs will be strict with timekeeping. After each presentation, there will be a 2-minute Q&A session where our judges will have the opportunity to ask questions. Our timekeeper will ring the bell once at 8 minutes of presentation and twice when the time ends. Now that the stage is set, we will have our first presenter up on stage. Please welcome Puan Aini binti Musa, a clinical dietitian from Dietetics and Food Service IKN, who will be presenting her research titled Preoperative Dietary Strategies and Body Composition in Bariatric Surgery, a Retrospective Analysis.
Hello. Okay. Thank you, Doctor, for the introduction. So, Assalamualaikum and good day to the judges and all. Today, I'll be sharing a study on preoperative dietary strategies and body composition in bariatric surgery, and this is a retrospective analysis. I am Aini Musa, and I am a dietitian from IKN. As we know, obesity is a major global concern worldwide, and according to WHO, 1 in 8 adults is actually living with obesity, and in Malaysia, the trend is also rising that leads to a higher morbidity, mortality, and also healthcare costs. Bariatric surgery is one of the key treatment options, and the prehabilitations or preparing patients before surgery is actually very essential and crucial. Preoperative weight loss is actually one of the elements of prehabilitations that could help to reduce complication as well as to enhance post-operative success. In IKN, there are 3 dietary strategies preoperatively. One is basic bariatric diet plan that was created to resemble the protein and also the energy provision from MRT using the whole food rather than a commercial product. And it serves in 4 meals in a day. Meal replacement therapy itself that are using whey-based meal replacement. This is served 6 feeds in a day, 3 hourly, 6 times per day. And the other one is for outpatients, which is low-calorie diet that serves slightly higher calorie, which is around 1,200 kilocalorie per day. So all these diet strategies has its own pros and cons, depending on the practicality to the cost as well as to patient's compliance. So what we wanted to evaluate or to investigate here is the outcome of the preoperative dietary strategies towards body composition before surgery. Hence, we conducted a retrospective observational study of 88 bariatric patients in IKN. Data were traced from medical record as well as dietetic records, and body composition was measured using Tanita, both during the baseline as well as post-intervention. And the statistical tests were applied and significance was set at p less than 0.05. These are the socio-demographic characteristics of the anthropometry and body composition between groups. And as we can see here, all the three approaches were actually effective in producing weight loss pre-operatively. However, MRT is superior in terms of not only producing greater fat loss, but also preserving or even increasing lean muscle mass, which is desirable pre-operatively. Again, as what I mentioned earlier, all the three strategies is actually effective in producing a significant pre-operative weight loss. Having said that, there are notable differences between the body compositions outcomes between the three groups. As in line with other previous study, MRT is actually the most effective as well as the most common being used pre-operatively. In this case, this may likely because of the high whey protein formulation that we used, and also it is served in a more small and also frequent feeds, which is 6 times per day. So this regime may help to promote more anabolic protein response and also protect lean body mass despite using a very low calorie diet. Okay, another options of inpatients, BBDP on the other hand, also demonstrate the benefits. BBDP is relied mostly on whole food, but the compliance might be the issue, where BBDP is served in more bulkier form and also less frequent, about 4 times per day. It makes less compliance, that can lead to less or inadequate intake of protein and weaker anabolic response of protein synthesis. Okay, however, we believe that BBDP has its own great potential as an option if we optimize the design. For example, we can make it more smaller and more frequent meal to mimic the MRT frequency, which is 6 times per day, that may enhance the compliance. We think this is very valuable as it offers the advantage of whole food and increase more satisfaction and reduce diet fatigue among the patient. Okay, LCD, on the other hand, is still feasible, cost-effective, and sustainable, but the compliance is relied heavily on the self-discipline of the patient. And what we can highlight, another point that we can highlight here is the differences between the inpatient setting as well as the outpatient settings that demonstrated by the results of LCD. Hence, it confirms that more structured and more well-monitored as well as more supervised approaches is actually give more effectiveness. Okay. For the conclusion, we do think all the strategies is effective, but MRT is the most superior, but BBDP can be improved and optimized. LCD remain practical and sustainable, but adherence is the issue. Hence, the choice of strategy should balance the effectiveness, compliance, cost, and patient needs. Okay, these are the references, acknowledgement, and with that, I thank you.
Now we open the session for the judges to ask their questions.
Thank you for your presentation. So I would like to ask, patients are given these 3 choices, right? These 3 choices of dietary strategy. How do you choose which patient uses which strategy? And do you think this would be a confounding factor, you know? What kind of patient does inpatient strategy? What kind of patient does the outpatient one?
It actually does affect, but in a real situation, it's actually the prehabilitation is divided into 2 stages. One is the prehabilitation during outpatients for 1 month. That one, the patient is underwent the LCD phase, and then the more intensive prehabilitation that can be divided into two pilihan tadi lah, 2 choices of BBDP and also MRT. That one is 14 days.
Oh, so you mean every patient will undergo the one
phase
month
one.
LCD first,
Yes,
then go into the
yes,
2 week inpatient
Yes.
strategies?
We actually just want to know the outcomes, whether or not patient need to be admitted. We just want to know whether dia punya outcome to give a very significant difference or not. If it's with prehab patients, outpatients only, or we need the intensive rehabilitation during the 14 days. But it does give a confounding factor, of course lah.
The other question is, I'm sure there are other strategies being implemented, right? Like physical activities.
Yes, of
So do you
course.
think this also affect the results?
Yes, but during the outpatient first rehabilitation, the patients also was teach on the exercise, but they need to do it themselves lah dekat rumah. Same like the LCD. When inpatient, they are very structured, and also they need to go to the gym daily. Of course, that one is also affects the results.
Hi, I was just wondering whether your patients who you know, for the outpatient strategy, did you all actually give the patient like a checklist of what are the things to do, you know, at home so that it be standard for all those patients? That's one. And also, how was the patient, especially those who are inpatient? Like, I think it's an extension from what Dr. Tong said. How did you, like, you know, you have like inclusion criteria or something like that that you chose, you know, for those patients?
In order to choose which one,
Who would
which
actually, yeah.
strategy. Yes, to answer your first question,
you.
yes, we do have, because we counsel the person in individualized, and we also cater the diet individualized lah. And then for inpatient, it actually depends also on the clinical decision by the primary team. Then usually the BBDP is given to the patient that have inability to tolerate the susu or the enteral product. It's just an option for the patient. And the decision is made by the primary team lah.
Do you still have time for questions?
Yeah, we still have time. Yeah.
Right, okay. Thank you, great presentation, Ms. Aini. So I have two questions actually. Number one, did the patients who receive LCD treatment, were they being consulted frequently for the period of, during the period of, you know, intervention for the 1 month? And what is your opinion regarding the comparable groups? Because it is quite obvious that these two groups were admitted, so they can't really, you know, have choice in terms of their diet. But those who receive LCD, they are, you know, at home, they have to prepare their own food. So, I mean, when I read your research, I think it's probably not too surprising that, you know, in terms of the weight reduction, all those your parameters, the least, the outcome is the least, what you call it, preferable is to the LCD, right? And I think the component of not staying in the ward really play important part. What's your comment on this?
Okay, the first question. Okay, we do have one consultation with the dietitians during the baseline, as well as 1 month after. Only 2 times lah, 2 points of time during baseline as well as 1 month after. So in between, we don't have any follow-ups with the patients. And then the opinions, of course, the MRT is obviously more superior, and also in line with the many previous studies juga lah. But its BBDP is actually, we actually intend to compare MRT and BBDP, and we just want to see the outcomes of 3, and to just see the outcome, to just compare whether it give a similar outcome or not.
We have run out of time, so thank you, Puan Aini, for that insightful presentation. We'll move on to our next presenter, who is Dr. Nur Nadiatul Ashikin binti Bujang, a public health specialist from the Non-Communicable Disease Unit, Occupational and Environmental Health Unit, PK Lembah Pantai. Her research title is Epidemiological Insights from a Mumps Outbreak in Co-Located Schools, Kuala Lumpur, Implications for Control. Yes, you may begin.
Assalamualaikum and a very good afternoon to the respective judges and everyone. I am Dr. Nadia from Pejabat Kesihatan Lembah Pantai. So today I'm going to present my research on epidemiological insight from a mumps outbreak in a co-located school in Kuala Lumpur. Now, mumps is a highly contagious disease caused by paramoxyviruses. It spreads through saliva and mucus with an incubation period of 12 to 25 days. In 2016, Ministry of Health have introduced 2 doses of MMR vaccination for those aged 9 months and 12 months. However, there are still pockets of outbreak in a highly vaccinated population in Malaysia, especially in schools. And schools are considered as high-risk environment for rapid spread and also prolonged outbreak. This could also because of potential immunity gaps or evolving virus strain. And on 28 October 2024, Lembah Pantai District Health Office have received a notification of a mumps outbreak in a co-located school in Kuala Lumpur. So this is the school. There is 2 different schools that share the same gated area, canteen as well as bookstore. And they have separate building as well as different administration staff. And there is also one religious school located at the 3rd floor of SKB 1, where they also have different administration staff and teachers as well as students, but 90% of the students are those attending SKB 1 and SKB 2. Oops. So this is the timeline of the outbreak, where we first received the notification on 28 October, where 15 of the students in SKB 2 have been diagnosed with mumps. And subsequently, there are a series of ongoing investigation and case detection from 28 October to 3rd December. And on 5th November, EIP team or Epidemiology Intelligence Program team from Ministry of Health have actually facilitated the investigation and control measures. At this point, there's already 2nd generation infection of mumps. And on 2nd December is the last case reported and the outbreak ended after 2 incubation period, which is 21st January. So the objective of this study is to describe the epidemiological characteristic and determine the risk factors associated with prolonged mumps outbreak among students in a co-located school in Kuala Lumpur. So this is the methodology. So basically, the outbreak investigation consists of 3 main investigations, which is the epidemiological investigation, environmental and analytical analysis, where for epidemiological investigation, case is defined as any individual with enlargement or pain or tenderness of the parotid or salivary gland with or without fever, who study or school at SKB 1, 2 or Kalfa, SKB 1, and have EPID link from 28 August 2024 to 2 December 2024. So for those confirmed case are lab diagnosed, either they are lab diagnosed or made the clinical definition and have EPID link with the confirmed case. And case detection are based on active case detection and also passive case detection. Now, for environmental investigation, a walkthrough survey have been also conducted to look for the spacing and crowding in the school area. And for the analytic part, for the actual outbreak, the number of cases was 58 with attack rate of 5.7. The exposure at that point was 1,016 and 59% of the cases involved male and 100% actually presented with parotid swelling. And it involved higher proportion of them are in the primary school. Now, from that outbreak investigation, it is actually our data source for this research, where we conducted a case control study with a case control study with a ratio of 1:2, with a sample size of 142, where the inclusion criteria include cases, those who diagnosed with mumps, and clinically fit the clinical definition, as well as they need to be student at either SKB 1, 2, or CAFA SKB 1, where those controls are matched by gender and also grade. Okay. For analysis, binary logistic regression analysis was conducted using backward method and JAPS software. And data collected for data collection is the sociodemographic characteristic, clinical data, vaccination status, as well as the gathering activities. Now, as for the result, this is the epidemic curve of the mumps outbreak. So the primary case was on 10th September 2024, where it was detected by active case detection. And the last case onset was on 2nd December 2024. And the outbreak was declared over by 21st January. As you can see here, there are increased number of cases after multiple school activities, but Lembah Pantai District Health Office just received the notification after the sports day on after 26 October. Now, these are the distribution of cases and attack rate. There are high proportion of those from SKB2 were actually the cases, which accounts for 87%. And the attack rate of this among students is 6.3%. And there's 54.3% are from lower primary students. Okay. As for the socio-demographic characteristic, male accounts for 60.9% of the cases. There are 95.7% of Malay ethnicity were also cases. And in terms of vaccination status, about 87% received at least one dose of MMR vaccine, and 87% involved in the school activity are cases. Okay, when it comes to factors associated with mumps cases, these are the binary logistic regression analysis that were conducted. So Malay ethnicity were found to be more likely to be infected with mumps. And as compared to B40 group, those in M40 were less likely to be infected. And those who received at least one dose of vaccination were less likely to be infected and is statistically significant. But those with 2 doses, although not statistically significant, have also the direction of association leads to less likely to be infected as well. And those involved with school activities were 8 times more likely to be infected with mumps. And for the environmental factor that could be the potential source of infection is the school canteen, where both schools share the same area. Prior to outbreak, there are only 2 recess time for both schools. And the disinfection is only done by the canteen staff. And also for the religious school, the Khalfa, there is no distancing enforced, and 90% of the students are from both schools, SKB1 and SKB2, and 11 cases were reported attended Khalfa. So during and post-outbreak, we enforce in terms of gatekeeping practice, which was not done before, as well as hygiene practices. Now, as for the discussion, as we can see here that there's high coverage of vaccination among the school children, but there are still outbreak. This could actually potentially, the potential contributing factor could be because of waning immunity or the school itself because of the crowding area. And therefore, it is important to have a tailored strategy required for effective control, especially in terms of surveillance, continuous monitoring despite mumps being a non-mandatory notifiable disease. And it is also recommended for the health facility school as well as the state education office to inform early if there's any mum cases or any infectious cases or outbreak involving school. Now, as for vaccination strategy, addressing the potential waning immunity, especially among those lower primary school, is very important because this trend suggests that there is declined immunity, especially among those lower primary age group. Therefore, we suggest if there is potential for any additional dose or implement outbreak vaccination. So in conclusion, this outbreak underscores the complex interplay of demographic, socioeconomic, and behavioral factors in mumps transmission. Findings suggest a targeted intervention, and we also recommend developing a mumps outbreak management guideline, which is not available for now. And therefore, re-evaluating national immunization program is also something that could be done. Thank you.
Now we move on from questions for the judges.
Okay. Excellent presentation. So I have a few questions. Can you go to your methodology slides? I think you have another slides previously, isn't it? Right, okay. So is this part of your methodological slides or just part of your introduction?
This is to explain about the broader outbreak where I take up the data to run my analysis. Because for my study, I focus on the student who attended the school, basically focusing on those primary infection, first generation only.
Right. Because a general recommendation is that when you present your methodology, you won't put your part of your result, for example, the attack rate in the methodology slide. Okay. And can you go through your logistic regression slide?
Sorry.
Not the one yet. So, did I get it right? If you can see the adjusted ratio for ethnicity for the Malay, do you mean that your adjusted ratio is 7.46, but the range is 0.123 to 3.895? Is that the range or?
Oh, okay. Oh, you mean the confident interval?
Yeah, confident interval, because the result is, the confident interval is not, your result is not in between the
Yes, I
confident interval.
understand. It does include one, right? Okay, sorry for that. Actually, there is a bit of typo when I did this slide. This is not a confident interval for this odds ratio.
I see. Because
yeah.
you can see that all your adjusted
Yes,
ratio,
yes.
the range is, not
I
in the
understand.
parameters. So, can you explain a little bit more on this, your finding? Because as you rightly point out that in terms of factors associated with cases, those that significant were, in terms of risk factor, you found that Malay ethnicity and also involved in school activities are the factors associated with mums, and despite that they receive one dose.
Yes.
Understand what I mean?
Yeah.
Meaning to say that even though students who already receive one dose of vaccination, they are at risk of mums if they are Malay. Yeah, am I right?
Yes.
So my question would be two-part. Number one is, why do you think, despite receiving one dose of vaccination, that you feel that is adequate, Malay ethnicity still had risk to be infected with mumps? And number two, you mentioned in your suggested findings that targeted intervention should be targeted in terms of socioeconomic status, right? So how do you propose to do this with regards to your findings? Because, sorry, I just want to point out another suggestion is that usually what we, for recommendation, any study recommendation should tailor to whatever that your study findings. Let's say if your study findings, you found A, you should recommendation is targeted to A, rather than your findings is A, but you are suggesting B and C.
So thank you very much, Dr. Azman, for the question. So as for the recommendation, actually for mum study, there's not much study related to the factor associated published. So most of the study we're talking about the genomic sequencing, we're talking about what are the prevalence instead of looking at the factors. And there are very limited study when it comes to Malaysia population. And when it comes to comparing either Malay ethnicity compared to other ethnicity, should we give more attention? I could say that in this study, because 90% of the population is Malay ethnicity, so that could also answer why there are high chances of getting mumps infection. And when it comes to receiving doses of MMR vaccine, for this case, I think in this study, although those who were receiving one dose of MMR vaccination were more statistically significant compared to those who received two. I think at this point, we need to explore further, and because this study is using a secondary data, we should have other contributing factors as well in order for us to understand the actual association and what are the factors that could be contributing to this. Okay.
Okay, thank you, Dr. Nadia. I see that you have a lot of supporters today. I just have a very quick question. What is your sampling method, and what are the limitations of your study? Thank you.
Okay, thank you very much. For the sampling method, it's a convenient sampling because for this study, we use the outbreak data, outbreak investigation data, where we recruit only those in the school. But for the control, we actually try to match by gender and grade and try to make it as random as possible. And for the limitation of the study, there are a lot of other variables that were unable to be included in view of the limited time, and we also are using secondary data. So the available data that were analyzed, or the factors that were included in the analysis, were the factors that is available. So we cannot get a lot more other variables that could be adjusted in our study. Thank you.
Okay. Thank you, Dr. Nur Nadiatul, for that insightful presentation. Next, we will invite our next presenter. She is Puan Roslini binti Abdul Aziz, a nurse from Klinik Kesihatan Sentul, PK Kepong. She will be presenting on her research titled Association Between Socio-Demographic Factors and Perceived Barriers to Continuing Education Among Public Health Nurses.
Assalamualaikum and good afternoon to all the judges and audience today. So my topic is regarding association between social demographic factor and perceived barrier to continue education among public health nurses. So I am presenting the nurses here. So I am Roslini binti Abdul Aziz, and actually this is my FYP from UiTM. So my supervisor is Madam Suzana Yusof. So as we all know that nurses are the pillar for the Ministry of Health and also the pillar for the health system in Malaysia. So nurses are required to enhance and furthering study for the enhance their knowledge and for the quality healthcare and also for the professional growth. However, there are many nurses face barrier and challenging in pursuing their education, including time, financial constraint, family responsibility, and lots more. So the previous study from Reyes and Conde and also Chris Bunny suggests that social demographic factors such as age, income, marital status, education level, and home location strongly influence whether nurses can access and complete the continuing education's opportunity. So the problem statement for the study, generally this study is address this gap by examining the association between socio-demographic characteristic and perceived barrier in continuing educations. Research objective, general objective, is to determine the association between socio-demographic factor and persistent barrier to continuing education among public health nurses. And specific objective is to determine perceived barrier and examine the associations between socio-demographic and continuing education barriers. So my methodology is a cross-sectional quantitative study, and the setting was held in Kebun Health Office, Kuala Lumpur, with a sampling population is 236, and after the calculated by the Rosov calculations, the total number of respondents is 122. Inclusion criteria is registered public health nurses in working in Kebun Health Office, grades U5 to U6, and inclusion criteria is nurses on long-leave maternity and admin nurses. So the data were collected from October 2023 to December 2023 using a Google form in an official WhatsApp group. Data was analyzed using the SPSS for the descriptive statistics and inferential. We used the chi-square and Pearson correlation. The ethical was obtained from ITM and also from the NMRR. Summary of the questions, there is two sections, which is Section A, socio-demographic, and Section B, the perceived barrier for nurses to continue education. For the Section A, there is 8 items, and we use the open-ended question. For the Section B, there is 9 items, but was divided into 3 domains, which is personal barrier, interpersonal barrier, and structure barrier. The question is closed-ended question using the dichotomous choose case, yes or no. And this question is already have approval from the previous study is from Oyango 2012. So the result for the socio-demographic finding, the total respondent was 122. So the highlight result is the one who had the associations p-value, which is for the gender, female 170, for the marital status, married 160 respondent, family income between 9,000 to 6,000, 50 respondent, home location less than 25 kilo from workplace is 69 respondent, and education, most of the respondents are diploma holder, which is 93 respondent. So the result for the persistent barrier, there is 3 domains here for the personal barrier, interpersonal barrier, and structure barrier. The result is gray color representative the no answer, and the brown color is representative the yes answer. For the personal barrier, respondents, most of the respondents agree there are time constraint, domestic responsibility, financial constraint, and also age and physical constraint are the barriers for them to continue educations. For the interpersonal barriers, respondents disagree that there are lacks of co-worker support and lack of family support. And for the structure barrier, most of the respondents agree that work commitment, lack of accessibility, and lack of organization support are the structure barrier for them to continue educations. So the result for the association between socio-demographic characteristics and barriers and personal barriers, the highlighted one is had the significant result, which is time constraint with marital status, time constraint with home location, time constraints with education, and financial constraints with the family income. For the result, socio-demographic characteristic and interpersonal barrier, there is an association between lack of family support and education. For the socio-demographic characteristic and structure barriers, there is a significant result for the lack of accessibility and home locations. So the discussion, persist barrier to continue education, domestic responsibility, 82% report family commitment and as a major barrier. Financial constraints, 74.6% face financial challenges in continuing education. Time limitation, 70% identify lack of time as a barrier. And these all findings are consistent with Malapati 2019 with highlighting the workload, family roles, and institution barrier as a key challenges. Association between socio-demographic factor and barriers to continuing education. Married nurses face more time constraint due to family commitment. Lower income nurses experience greater financial barrier to pursuing education. Nurses who live in less than 25 kilo away report highlight time limitation. Higher education level are linked with the less family support due to competing priorities. The implication and recommendation, Ministries of Health and healthcare institutions should improve access to continued education, provide financial support and create flexible schedules. Recommendation, introduce online and hybrid learning for flexibility, enhance workplace support through mentorship program and reduce workloads. So for the conclusions, major barrier, domestic responsibility, financial constraint, time limitations, and commitments, and work commitments, significant association were found between socio-demographic factor and barriers, marital status, family income, home location, education level. Limitation and further study, cross-sectional design, single-site focus, self-reported data, and expand regional focus, longitudinal research, and intervention studies. So the acknowledgement for the Director General of MOH, Supervisor, and those who involved in this study. Thank you.
Okay, questions from the judges?
Okay, thank you for your excellent presentation. I was just, out of curiosity, because what I see is actually more than 90% or 95% of your patients, your samples are actually female nurses. So, will it, if there's not much male, whatever your finding is, will it sort of extrapolate to them? Do you think?
Because we already know most of the nurses are female. So because I'm working in public health, so in KK, so I cannot find more male respondent compared to hospital.
Ms. Roslini, great presentation. What I'm dying to know is that perhaps you don't make it very clear. Since your study is looking at perception, isn't it?
Yes.
So, do you think the perception is different between nurses who already, like yourself, already continue pursuing education, compared to those who never been or never, never had any continuing education? Because from these 122 respondents, you didn't tell us whether who have, pursue education and who hasn't. Would you think it will make a difference? Because we are talking about perception, isn't it?
Okay,
because if you're the one who answered this questionnaire, right? Let's say this study is being carried out by your colleague. Do you think you will answer differently compared to those who haven't, pursue continuing education? Number one. Number two, it is interesting because one of your findings is that married nurses find, time constraint. So what are we going to do about it? Because you cannot ask them not to get married, isn't it? This is something that you can't really, do anything much about it. But I would like to see some recommendation. For example, because you mentioned married nurses have, think time is constrained. Perhaps Ministry of Health need to think to remodel the education curriculum that make it much easier, lesser time constraint compared to the current one. I think that will probably going to be a better recommendation.
Okay, for the question number one, if I not mistake about what you're trying to ask, is yes, there is a difference between nurses who are not furthering study and nurses who not furthering study. That's why I do this research, because I was surrounding with the friends and staff who have a reluctance to continue the study, but there are some group, a small group who are maybe like me, want to continue my education. So yes, my study, I did not mention about the Yes, but maybe we can see at the result of socio-demographic, the education level. That's the only thing that can be the difference. So the post-basic degree holder compared to diplomas. Okay. Yes, yes. So it's a small number actually. Okay. For the questions number 2, I've not really understand, or maybe yes, married nurses are the main here. We cannot prevent them from marriage, but all I can do is, all I can suggest actually, maybe like my suggestion at the last slide is online studies, or they don't need to wait for the turn to continue study. As we know, as maybe you don't know, we have to wait the seniority to further study. So in between, we wait for the turn, we get married, and when we get married, we have a child, and that make the time constraint to further study. So I hope in the future there is a hybrid learning, and also nurses don't have to wait a certain time to continue study, such as degree. We have to wait for the post-basic first and go for the degree. Yes, maybe. Okay, thank you.
Okay, I can see that you are very enthusiastic about nurses continuing their education.
Yeah.
Just a simple question. Your participants all from Kepong Health Office?
Yes. Betul.
So they are not from hospitals or other
No.
institutes. So do you think if you involve nurses from different institutes, your results will be different?
Yes. My result, actually my study at one point and on one district office only. So it cannot be used in other facilities and with different managements. Okay.
Thank you, Puan Roslini, for that interesting presentation. Last but not least, I would like to invite Dr. Nik Nur Fakihah binti Nik Sukiman, Medical Officer from the Unit NCD PK Lembah Pantai. She will be presenting her research titled Immunochemical Fecal Occult Blood Test Screening for Colorectal Cancer, Demographic Profile and Associated Factors in a Primary Care Setting.
Assalamualaikum and good afternoon. Thank you to the respected chairperson, judges, and also my fellow colleagues. My name is Nik Nur Fakihah binti Nik Sukiman, and today I would like to share our case study entitled Immunochemical Fecal Occult Blood Test I4BT Screening for Colorectal Cancer, a Demographic Profile and Associated Factors in a Primary Care Setting. So, this study was actually conducted under Lembah Pantai Health Office in collaboration with my co-authors, whom I would also like to acknowledge at the start of my presentation. Okay. So, colorectal cancer is actually currently the second most common cancer in Malaysia, and according to National Strategic Health Plan for Colorectal Cancer 2021 to 2025, it is now the major burden in public health. So, the challenges that we face is that many cases detected at advanced stages, which limits our treatment option and also reduce the survival rate. And to improve the early detection, Ministry of Health Malaysia actually introduced free I4BT screening in primary care setting in 2014.
So I4BT screening is actually a very simple test and non-invasive, which can be done opportunistically during clinic visits. However, the screening uptake can vary, depends on the different demographic variables, which the importance of the study I will highlight in my presentation. Okay, so therefore, this study is aimed to describe the uptake of I4BT screening and determine the demographic factors associated with positive result, especially in Lembah Pantai area. So, for the method, this was a cross-sectional analysis using secondary data from 3 primary healthcare clinics under Lembah Pantai Health Office. The inclusion criteria is all individuals who underwent I4BT aged above 18 and Malaysian citizen. The period time is from January 2023 to June 2025 with the total sample of 2,197 individuals. So the analysis was conducted using logistic regression with JAS software. Okay. Now moving on to the result. Out of 2,197 population, 279 was actually detected with positive result, which represent the positivity rate of 12.7%. And when we look to the age distribution, we can see that majority of the population screened were aged more than 61 years old, and then followed by the age group of 50 to 60 years old, and then less than 50 years old. And in terms of gender, the distribution is actually fairly balanced between male of 47.5% and female 52.5%. Okay. If we look at the ethnicity distribution, we can see that Chinese population is the majority of the screen group. And from our finding, we can see that the older age group, specifically more than 61 years old, associated with positive I4BT result, with OR of 3.57 and confidence interval of 1.11 to 11.51, which is statistically significant with p-value of 0.033. And then I would also want to highlight the important finding, which is out of 79 participants who underwent the colonoscopy, actually 2 cases was detected as colorectal cancer, and 26 cases was detected as colonic polyp. This shows that I4BT screening have a valuable clinical value in detecting the precancerous lesion and also can detect early stage of cancer. So moving on to discussion, from our analysis, we can see that Chinese ethnicity has the majority of the participant, which is 56.2% of those screened. And this is important because, as mentioned in Ministry of Health 2021 report, the highest incidence of colorectal cancer incidence in Malaysia is actually among the Chinese population. And then secondly, our analysis shows that older age group is more likely to have I4BT result positive, and so our screening should continue to prioritize this older age group. Okay, and then there is 5% of participants refuse to do colonoscopy, and this finding is similar to the previous study, which shows that older adults may be less willingness to do the further screening because of the negative perception, and also they are afraid of the further invasive testing. So this highlight the need to maintain not only the accessibility to I4BT screening, but also we need to improve the awareness and acceptability for both I4BT and also colonoscopy. Okay. Despite our limited numbers of variables in our data set, actually our findings provide valuable insight into screening uptake and factors associated with positive I4BT outcome. Okay, and based from our finding, so here is our several recommendation. Firstly is to enhance the awareness campaign to overcome the negative perception and also to increase the willingness of participants to do I4BT screening. And then secondly, to ensure timely colonoscopy follow-up for all positive I4BT cases. Because as we all know, I4BT screening is only the first step of the screening, but the proper follow-up and colonoscopy is very important to determine the diagnosis and also the choice of treatment. And thirdly, a systematic and accessible data, which is important to support monitoring, comparison, and planning to strengthen the colorectal cancer prevention in primary care. And finally, we should strengthen our data system to improve monitoring through digitalization, which can help for comparison and also provide evidence to guide national prevention strategies. So this is actually the image of our dashboard for written colorectal cancer under Lembah Pantai Health Office, which make it easier for us to monitor the trend of colorectal cancer. So in conclusion, our study shows that older age was significantly associated with positive I4BT result, and these findings support the continued screening among older adults. And making the screening data more accessible can enable comparison across time and setting and contribute to strengthening the colorectal cancer prevention strategies in primary care. This is our reference. And with that, I would say thank you for your attention.
Now we open the session for our judges to ask questions.
Thank you, Dr. Nick. So my first question is, in the hospital, we are not encouraged to send this fecal occult blood because of a lot of false positive. From your reading, what are the potential false positive in a primary care setting? Number one. Number two, from your results, would there be any, would you change a recommendation for doing this screening? Or would you, modify the recommendation for a certain age group maybe? Thank you.
Okay, thank you, Doctor, for the question. So actually, answering to the first question, I think to detect the false positivity, I think that part maybe we should explore more, because in the clinic part, we do I4BT screening. This one is to detect the occult blood. So, but we don't know the outcome actually. So this is why we use our written. We make use of our data and analyze it, and just make a study to show which outcome, which will be the possible outcome lah. But for the false positive part, maybe we can explore more later. And then, Doctor, for the second question, can you repeat? Sorry. Oh, okay. Actually, based on the previous study, the significance for doing the I4BT screening actually shows it's more on the older age. So to get benefits and also make use of our resources, I think we can follow what is actually shown based on our analysis lah. Thank you, Doctor.
Any more questions from the
Okay,
judges?
actually, my second question was the same as
okay.
Dr. Tong. But I was just wondering also, there is, I think I wanted to ask just now, that when you all did this study, because you all sent your patients, those who are positive for colonoscope, how easy was it to get for these patients? And or was it like you all had an close relationship with your surgeons or your colorectal surgeon to get this done?
Yeah, actually, our primary healthcare clinics, we have a WhatsApp group with HKL, SOPD department. So they actually allocate a quota for our clinics to do colonoscopy for this I4BT screening. And then, but depends on the quota given. So some of the patient may get late appointment. So that is the challenges that we face.
Can we go to your results slide? I think you have 12.7% positive I4BT, right? But I think the number that went for colonoscopy didn't add up, isn't it? I think you're missing a little bit of numbers.
Yeah, 79.
Yeah. Sorry? No, I mean 17. I mean, supposed to be 279 should go for colonoscopy, isn't it?
Yes.
I see, right.
Yeah, but some patient refuse to do colonoscopy.
They refuse, yeah, because 79 plus 26 and 21 didn't really add up to 279. Anyway, in your personal opinion, right? Because when I'm seeing this result, you eventually had 2 cases out of 2,179 patients being screened. In your personal opinion, you think it's successful? Are you happy with that?
Okay.
And I mean, in terms of recommendation, based on your own findings here, there are some, I can think of some things that you can do in your own clinic. For example, those who are elderly more than 60 that go for follow-up, for chronic disease, you can also, you can persuade them to take up the screening. Yes. And there are some other things. But what else do you think you can do for your, to increase the number,
Yes.
the yield of the positivity?
Yeah. Actually, we noticed that the amount is quite low for patients who underwent the colonoscopy. And as Dr. Azman said, it is, in my opinion, it's very important to improve our health education and awareness. And then this data is actually shared to our clinics. So we also encourage our medical officers who encounter patients, especially older age patients, to persuade them to do this screening. And then the first question is about... Oh yeah. Actually, I'm satisfied because out of all patients that is tested positive, small amount is willing to do colonoscopy, but it's okay. Only 2 patients detected as a colon cancer. Maybe we see it as a very small number, but actually we can see that 26 cases was detected as colonic polyps, which is, I think is a very successful because we can detect the precancerous lesion and can detect the early stage of cancer.
All right. Thank you, Dr. Nik Nur Fakihah, for the fascinating presentation. I hope our judges are satisfied with the answers provided. And that concludes our oral presentation competition today. Let's give another round of applause to all our presenters for their outstanding work, and also to our expert panel of judges. Before we end this session, we would like to present a token of appreciation to our judges. I would like to invite Dr. Chen Pei Ming to come up to the stage to present the tokens. Firstly, can I invite Dr. Tong to come up? Can I invite Dr. Tong to come up to receive the token of appreciation? Next, I would like to invite Dr. Patricia to come up to receive the token of appreciation. And last but not least, Dr. Noor Azman, who had many burning questions. Can I invite you to receive the token of appreciation? For the judges, you will be escorted to the holding room to tabulate the results later. We will now adjourn the session, and winners of the oral presentation competition will be announced during the research day opening ceremony tomorrow. Please do not forget to visit the booths and research posters on display at the lobby on your way out. Thank you all for attending, and please enjoy the rest of the event. Have a great day.